Hello, everyone. Today, we are going to talk about the endocrine station. The session is being delivered by Devika and myself. Welcome to BIDA Student Wing's last session in the OSCE Webinar Series. So the learning outcomes for this session is to learn the key points that you need to ask in a history taking with an endocrine diagnosis. You're also going to go through the neck examination, and then finally we'll end with an A2E scenario. So over to you, Devika.
Yeah. So in terms of an endocrine pathology, your presenting complaint, it can be anything. Some common presentations that you can see is a neck lump or swelling. And with that, you want to establish, is it acute or chronic? How long has it been going on for? Do they have difficulty swallowing? And if they do, is it with fluids or solids or both? And is it painful at all? And do they have any fever? Other things they can present with is tiredness, and you're asking similar things. Is it acute or chronic? Is it affecting their day-to-day activities? And do they have any other symptoms with it? Mood changes can be seen. So you want to see, when did they first notice it? How long has it been going on for? Is it only them who've noticed it, or have others as well? And you want to inquire about their concentration and their cognitive function. Weight changes are common as well. So it could either be going up or down. How long has it been going on for? Is it intentional or unintentional? And can they quantify the amount? So they may not exactly be able to say, I've lost 3 or 4 kgs, but they can say that my pants are looser, etc., something like that. And urinary or bowel changes, so polyuria, constipation, diarrhea. So in terms of someone's coming with something endocrine pathology or something with tiredness and weight changes, the best thing to do is first take a focus history on what they're presenting with, and then do a systems review, because that will probably tell you a lot. And endocrine pathology is something that can affect various systems. So at least if you do a systems review, you'll cover everything. Then you want to move on through your basic structure, do your past medical history, past surgical history, drug history, including allergies, family history, particularly important. It can give you many clues if there's something going on. And social history, so occupation, alcohol, smoking, recreational drug use, and diet and exercise. So if you at least cover all that, you should sort of get an idea about what's going on with the patient. Okay, on to you, Saloni.
Thank you. So when you go into an OSCE station, this is the kind of scenario that you will receive. So in this case, we have a 32-year-old female who's presenting to the GP practice complaining of a swelling in her neck. Her background history is that she's lost about 2 stone weight in the last 4 months. It has been unintentional despite her increased appetite. So you need to perform a relevant examination, and at the end give an S-bar to the examiner. So we would, in this case, perform a neck examination because we'd like to examine the swelling in her neck. Do you know what you're hoping to look for when you perform the neck examination? What kind of conditions would you be investigating? If you could put it in the chat box. Sorry, I'm not able to see the chat box. Right, so one of the main things you're looking for is thyroid disease and any other masses in the neck, any abnormalities. So you'd like to palpate the neck to see if you can feel any masses. So I'll go through that examination now. So the first step with any examination is to introduce yourself, gain consent for the examination, and then move on with general inspection of the patient, make sure they're comfortable at rest. So in this case, the patient will be sitting upright, could be on a chair, could be on the bed. And then start your examination by observing if they look very thin or overweight, because these could be signs of hypo or hyperthyroidism. Do they have an obvious tremor that you can observe? Are they sweating in the weather, or are they feeling really cold? Are they dressed appropriately for the weather? So if they're really cold during the summer, you would think that this might be a sign of hypothyroidism. Observe their behavior, if they're fidgeting, anxious, and also their breathing pattern. Are they breathing too fast? Because these could again point to thyroid disease. So start with inspection or examination of the hands. You want to feel the temperature on their hands. Are they too cold or too warm? Does anybody know what these signs are called? Any of these signs? I'll play this video if you can observe anything in it. So the first one on top here is separation of the nail bed, and that's called onycholysis. Here there's some swelling around the fingers. You can see mild clubbing as well. This is known as thyroid acropechy. Here you can see redness around the palms. So that's called palmar erythema. And finally, in this video, if you look at this hand right there, you can see a tremor. This tremor is really fine. So in an examination, what you can do is take a sheet of paper and place it on the patient's hand as they've kept it outstretched like that. You'll see the paper move. It will make it easier for you to detect the tremor. So does anybody know why we would check these signs, or what these two signs would point to? Any conditions? You guys can guess and put it in the chat box. There are no wrong answers. At least there's an interaction. We can see if anybody knows what the answer is. Yes, that's right. So we're looking at thyroid disease, specifically hyperthyroidism, especially with other signs combined. Thyroid acropechy can be a good sign of Graves' disease, which is autoimmune thyroid hyperthyroidism. So next, you would check the face and comment on any coarse features around the face. So if you look at this type of hair loss that's usually seen in thyroid disease, the hair loss is, it doesn't have a pattern, it's the entire scalp that loses hair. In this case, if you look at the outer third of the eye, that's lost. And here there's some swelling around the eyes, that's known as periorbital edema. And finally, in this picture, there's exophthalmos. So what that means is bulging of the eyeballs. For this step in the examination, you need to look at the patient from the front, get up, and then look at the patient from the sides to see if there is this bulging of the eyes, as it would be more obvious if you're looking from the sides. And then go behind the patient, warn them that you're going to look from the top of their head as well. So you can look at the exophthalmos clearly if you look exactly from the top. Now for neck inspection, you need to comment on the neck, what you can see obviously before you start palpating the neck. So here you can see a swelling. Does anybody know what this kind of swelling is called? It could be a cyst, but yes, it's more commonly known as a goiter. So this would be how a classical goiter would look like. It's a big swelling around the neck. And here you're also looking for any surgical scars, any previous old scars, any drains coming out of the neck, like this one here, or any obvious dressings around the neck. So make sure that you don't only look from the front, but also go to the sides of the patient and look. You have to be very exaggerated in your OSCE examination. So look from side to side, please. So your next step is to then examine, look at the eyes. So we already talked about the exophthalmos. You also need to examine the eyes. So do you see the eyelids here? In this one, it's more drawn back. So that's known as lid retraction. This is because of this exophthalmos in the eyes. And finally, in this video, there are a few signs that you can see. I'll play it now. And the first thing you can see is that the patient cannot converge as you bring the pen forward. They're not able to converge it towards the pen. So in this eye, the convergence is lost. Then as you ask them to look at the pen, they look up, but when you bring the pen down, the lids don't fall down at the same time as you look down. So that's known as lid lag. So in this video, you can see that there's a slow reaction as the lids come down. Does anybody have any questions about that? And thyroid these are known as signs of thyroid eye disease. Sorry, I answered the question itself. Moving on. So when you examine the neck, before you move on to palpating, you also need to check if you've missed any masses. So these can be exaggerated by movements such as asking the patient to stick their tongue out, and then observe if there are any masses that move as they move, stick their tongue out. Or also keep a glass of water, ask the patient to take a sip, keep the sip of water in their mouth, and then observe their neck, ask them to swallow it. As they swallow it, if there are any masses, they would move, like in this video. So this usually points to any masses that are attached to the larynx, and you would want to investigate further, or to the trachea. So finally, then you would want to palpate the neck. So to check for the thyroid. So if everybody tries to feel their neck and start feeling from your chin and then go down to your neck, the first bulge that you feel is your cricoid cartilage. Keep going down, and the second bulge that you feel is, the first bulge that you feel is your thyroid cartilage. The second bulge that you feel is your cricoid cartilage. Just under the second bulge, if you put your hands towards the side, you can feel the thyroid gland on both sides. It's a butterfly shape resting on the trachea like that. So in the patient, you'd be standing behind them like that. Make sure they're comfortable. You're not pressing the neck too hard. They're not in any pain as you do it. Remind the patient that they are in full control of the examination. If at any point they're feeling uncomfortable, you're happy to stop. So rest your fingers just like that, so you're able to feel the thyroid gland really well. And then whilst you keep one hand like this, start moving this hand in a circular motion to feel for the thyroid lobes. So you need to check the position. It's central, it's symmetrical on both sides, like a butterfly shape. Comment on the size. Do you think it feels too big? It should cover the tips of your fingers there. What is the consistency? It should normally be smooth, but has there been any abnormalities? Is there any nodes, nodularity that you can feel on the thyroid itself? And is the patient in any pain when you press on the thyroid gland? You need to do the same whilst placing your hand on the thyroid gland, and you need to ask the patient to stick their tongue out. See if your hand moves upwards as they do that, as one of the lobes could move upwards if there's an enlargement or any problems. And repeat the same when they're swallowing water. Finally, to examine the neck, you need to check for all the nodes. So starting with your submental, submandibular, your preauricular, then postauricular behind the ear, your anterior cervical chain, just down there, and your supraclavicular lymph nodes. So make sure you check all of that while standing behind the patient. Does anybody have any questions about that? So the last few steps in this examination is, if there is a goiter, if you think there is a swelling just behind the sternum, then you need to percuss it. So start from your neck and go all the way down to the sternal notch. And this is to check if there is a goiter, it would produce a different percussion note. And if there is a goiter, you also want to auscultate it to listen for any bruit, which is a turbulence in blood flow. Finally, examine the legs. So this is from the knee below. So you're looking for any swelling around the leg, which is especially just under the knee. So that's your pretibial myxedema, which would look somewhat like this. Any skin changes, so rashes, redness. And next, you need to check the reflexes. So if this is on a chair, just ask the patient to relax one knee on top of the other. So just cross their legs over and check for the knee reflexes. Is it more hyper-reflexive or hyper-reflexive? And then next, check the ankles as well. So the patient can put their knee up on the chair and just relax their ankles, and you can feel the reflexes, or you can put them on a bed and check their reflexes. So in our case, let's say when you examine the patient, you see that there's exophthalmos, there's goiter and thyroid acropathy. what is your diagnosis in this case? Yes, that's right. So your top differential here would be Graves' disease. So when you give your S bar, you would put it somewhat like this. So a 32-year-old female presented to the GP complaining of a swelling in her neck. She has a 4-month history of unintentional weight loss and increased appetite. On examination, she had thyroid acropathy, exophthalmos, and goiter. My top differential diagnosis is hyperthyroidism, likely due to Graves' disease. I would like to perform an ECG, bloods including full blood count, thyroid function test, and anti-TSHR antibodies, and ophthalmoscopy. So these would help you diagnose Graves or exclude any other causes. You need to do an ECG because you also need to feel the patient's pulse, as they might have tachycardia, which is seen in hyperthyroidism, and you want to rule out any arrhythmias that they have. You have to look into the eyes to check for acuity if their visual fields are fine, perform an eye examination as well if that's suitable. And the antibody test would diagnose Graves. Is that clear for everyone? Does anybody have any questions before we move on to the A to E scenario? Feel free to put the questions in the chat box whilst we're going through the next scenario. Over to you, Devika.
Thank you. Okay, so now we're going to discuss a case, and whenever you guys have an answer, just pop it in the chat box and we can discuss it. So here you have Sarah Parker, who's a 17-year-old female. She's come to the ED in the ambulance. She's presenting with abdominal pain, nausea, and vomiting. She has a history of type 1 diabetes. She's on insulin, but no other medications, and she's got no other drug allergies. When you're trying to assess her airway, the patient is able to talk to you and answer your questions. So can we assume that the airway is patent then? Yeah, since the patient's talking, even if they might be in pain, even if they might be vomiting, but as long as they're talking, they're maintaining the airway. So let's move on to breathing then. What sort of things do you want to look for in breathing? Just pop them in the chat box, anything you can think of. Yeah, that's good. So we're looking at some basic observations: a respiratory rate, oxygen. What about any examinations? What are we going to check in breathing? Yeah. So you're going to just basically do a more brief chest examination. So you want to percuss, you want to auscultate, and then investigations to consider would be either chest X-ray or an ABG. So yeah, you want to start with observations, a respiratory rate, oxygen. You want to do an examination. So again, inspect really quickly, check the trachea position, that's pretty important. Palpate, see the chest expansion, apex, B, percuss, and auscultate. And investigations, if required, things you can order are APG, EBG, or chest X-ray. So in this patient, her saturations are 94% on room. She's tachypnic, his trachea central. Her chest is clear, there's no crackles or wheeze, expansion is symmetrical, and percussion is normal. So any investigation you want to order right now before moving on to C? Yeah, an EBG is a good shout. So even though our oxygen's normal, but considering what she's coming with, and if we have a diagnosis in mind, it might be good to do an ABG or a VBG, depending on what we think is important and convenient. So for this patient, an ABG was done, and these were her results, and the normal values are there. Can you guys tell me what the ABG shows? It's okay, just have a guess. Yeah, so metabolic acidosis, some respiratory compensation. And that's, as we come to the diagnosis, become clearer why this is the answer. So you guys have guessed that correctly. That's perfect. Not mentioned here, but usually you'd also have a lactate and a base access. And we'll come back to the results of that. So at this point, are you guys thinking of any differential diagnosis? It's pretty early in your examination, but you have a history of a 17-year-old lady. You have these ABG results. She's presenting with nausea, vomiting, and she has a history of diabetes. Is there anything that's coming to your mind? Yeah, we're going to come to the BM. So I know it's not good we're not jumping to diagnosis, but they are just things to keep in mind. So DKA is what we're thinking at this point. If we are suspecting DKA, would her lactate be raised or would it be normal? Yeah, so a lactate is not mentioned here, but when you get an ABG or VBG, the lactate will be raised and her base excess will be more negative. So those are other things that can point you towards your diagnosis. So in terms of circulation, again, we're going to do basic observations, heart rate, blood pressure, temperature. We are going to check a capillary refill time, JVP, inspect her chest, listen for heart sounds. And again, investigations depending as needed. You can do an ECG, blood, culture, urine outputs, an MSU, etc. So for Sarah, her heart rate is 124, blood pressure is 140/90, temperature is 38, capillary refill times 4 seconds, heart sounds are normal, and JVP is not elevated. Do you want any investigations at this point, or should we move on to D? Yeah, so I mean, a capillary refill times 4 seconds, so you're suspecting could be dehydrated. She has been vomiting a lot. The temperature is mildly raised, could be raised since we're considering DKA. Her body's not feeling so well, so it's mildly raised, could be because of that. But she is tachycardic, so we can do an ECG just to make sure nothing else is going on. And other things, so you want to do an ECG, do her blood, so you do full blood count, use an ECRP, urine pregnancy test. So while she does have a history of diabetes, we have to think about other things as well. It's important to always check the pregnancy status in women of childbearing age and get an IV access. So that's what you want to do initially. And we did do an ECG. Any guesses as to what this shows? Okay, yeah, I mean, it's nothing confusing. It simply just shows tachycardia, about 150 per minute. Yeah, so she is tachycardic. There's nothing else on the ECG, but it's always good to get one to rule out anything else and to make sure it's just the body reacting. So in terms of D, what other things we're looking for? So someone did mention BM. That's perfect. What other things are we going to check? Yeah, so patient status, you want to check AFPU. You can possibly check GCS if you have time. So look at the body for rashes. That will probably come in E, exposure. But yes, pupils will come here. So we are checking patient status. So AFPU is usually the quickest one, and that's the one you usually go for. You can do GCS if you have a little more time and the patient's stable. Pupils, equal, reactive to light, blood glucose, it's a hypoglycemia, other things. In this case, particularly, you want to check the ketones as well. And then if you're suspecting a neurological sort of condition or pathology, then you can request CT and MRIs and go down that route. So that would all come under this area. Patient alert, GCS is fine. Pupils are equal and reactive to light and accommodating. Her BM is 30.1 and her ketones are 5 millimoles. Oh, well, sorry. Well, what sort of abnormalities have you guys identified from this? Yeah, high BM and ketones. So working diagnosis, I guess you guys mentioned this earlier. We're thinking of diabetic ketoacidosis. 3 main criteria to diagnose it is hyperglycemia, so glucose more than 11, acidosis, that's what we're doing. So while I did show an ABG, in emergency departments, they more commonly would do VBG. It's easier for the patient. While they're taking the bloods from the cannula, it'd be easy for them to take a sample. And ketosis, so either you do blood ketones, which are more than 3, or urine ketones, which is +2 on dipstick. Either one can sort of help you confirm the diagnosis. So how would you manage it? What sort of things do you want to give the patient? Yes, fluid replacement, that's good. Anything else? Yeah. Okay, perfect. So the first thing you want to do is before in diabetic ketoacidosis is you want to correct the fluid replacement before you go on to any metabolic abnormalities. In terms of DKA, dehydration, potassium imbalance, and acidosis are the things that can make the patient really unwell. So the priority here is fluid resus. What fluid would we give them? We'll give 1 liter of fluid stats. What fluid would that be? You'd probably start with sodium chloride because you're sort of trying to resuscitate them, get the fluid rate. So sodium chloride would be the first step. You can always add Hartmann's later. The first bag of fluid you give, you're not going to add potassium to it. You want to check the blood results that come and accordingly see, do they need potassium, and then give it at a standard rate. Someone did say fluid with dextrose. Wouldn't get dextrose at this point, but it's a good shout. Calcium gluconate, not necessary in this case. Insulin, yes, but calcium gluconate is not always necessary. It's always good to keep in your mind. So things to do. Oh, yeah, always check and follow your trust guidelines. Call for senior help if you're not sure. Fluids, resuscitate with saline stats, and then add fluid boluses with potassium. Always make sure you check the potassium and you keep monitoring it because it could lead to hypokalemia, hypo, and then that's just going to make the patient more unwell. Insulin given at a fixed rate, 0.1 unit mil per kilogram. Continue the patient's long-acting insulin, but you want to stop the short-acting. Glucose, monitor, so you don't want them to go into a hypo. So when they're reaching about 14 or go below, then that's when you want to add dextrose to make sure that it doesn't drop too much. Closely monitor potassium and treat as required. And then you want to check for infection, fluid status, and ketones level. Infections commonly you predispose them to get DKA. Other things is that they just missed the dose, they haven't been following the regime, or they didn't know that they have a diagnosis of diabetes. Check the fluid status and monitor the ketone levels. So once you've done that, you initially manage this patient. Always remember fluids before insulin. That's when you move on to exposure. So someone said rash, that's perfect. We're going to check for rashes all over the body, do a head-to-toe assessment. Anything else in particular you want to inspect? Yeah, so I would assess the abdomen as well. It's always good just to check. So in her case, you want to check for any tenderness, swelling, distension, guarding, rigidity. this is probably the, even if the patients come in with any other problem, like a respiratory problem, it's always good to just do it. Other things, you want to check calves for any tenderness, swelling, redness, and do head-to-toe assessment for anything else. So that's when you're checking for rashes, wounds, etc., anything else that could cause them to feel unwell. Urine output's a good shout. You can do that here. You can do that in C, where you are checking the fluid status. And you can also put in a catheter if you feel like you can't measure it properly, or the patients will not be able to give you an accurate reading for that. So there's no calf tenderness, redness, or swelling, no rashes. Abdomen, there's generalized sort of tenderness across the abdomen. There's no rigidity or guarding. Her bowel sounds are normal. So in DKA, you see in young patients, yeah, you can present with, the features of diabetes. So she can come with polyuria, polydipsia, etc. But you're thinking of other things, particularly vomiting, nausea. If they're really unwell, they can be disoriented, and dehydration. So you want to look out for these things as well. And that's about it. So good job, guys. You've correctly diagnosed the patient and you've managed them appropriately. So that's good. Do you have any questions? If you were given the scenario in a GP setting, how would it differ? So if you're suspecting a patient has DKA, you want to try and do the initial, you probably want to signpost them to A&E. So either call them an ambulance, ask them to go. Things which you can do in the GP is you can do their basic observations, you can monitor their glucose. It's highly unlikely there might be a cannula in the GP, but if there is, you might try and get some access of it. But you won't be able to give fluids or treat them properly. So best thing is signpost them to A&E. My colleague has posted a feedback form, so I'd really appreciate if you guys could just fill it. It'll only take a few minutes. This is our last session, so I really hope you guys enjoyed it. We upload the recording of all our videos on YouTube. It's just on the BIDA student wing, so you can have a look at it. It's accessible to everyone. Thank you for joining.